One maternal death occurs every minute worldwide. To put that into perspective, by the time you finish watching this video, an estimated total of 6 maternal deaths would have occurred. Even though it is not entirely possible to prevent all obstetric emergencies, it is crucial to recognize early warning signs, reduce the risk factors, and to anticipate the emergencies. And by the end of this video, you would have contributed to saving more lives simply by educating yourself and the others. So, what is an emergency? By definition, it is a serious, unexpected, and often dangerous situation requiring immediate action. Let's have a look at such emergencies in obstetrics. Here we have some numbers on the incidence of several obstetric emergencies worldwide. Bear in mind that incidence and outcome of these emergencies vary drastically from country to country. However, we can narrow down the leading causes of maternal mortality to thrombosis and thromboembolism, hemorrhage, sepsis, amniotic fluid embolism, and cardiac disease. But regardless of the emergency, it is essential that they are managed in a routine stepwise manner to minimize the damage to the patient. In this video, we'll discuss in detail about one such emergency, which is maternal collapse or unresponsive patient based on the latest guidelines from the Royal College of Obstetricians and Gynecologists. Check the link right below the like button to get your PDF copy of the guidelines. Maternal collapse is defined as an acute event involving the cardiorespiratory systems and/or the brain, resulting in a reduced or absent conscious level and potentially death at any stage of pregnancy up to 6 weeks after delivery. So what causes maternal collapse in the first place? In this diagram, you can see all the ways in which one could develop maternal collapse. But a rather simpler approach is to remember the reversible causes, that is 4 T's, 4 H's and E. The H's are for hypovolemia, which is mainly due to bleeding, hypoxia due to cardiac causes like peripartum cardiomyopathy, myocardial infarction, and aortic dissection, hypokalemia and hyponatremia mainly due to oxytocin use, and hypothermia, which is no more likely today even in countries with extreme weather. Then the 4 T's are for thromboembolism by amniotic fluid embolus and pulmonary embolus, toxicity by local anesthetics, magnesium and other drugs, tension pneumothorax, and cardiac tamponade, both usually due to trauma or suicide attempts. And the last E for eclampsia and preeclampsia. Now, the most important part, which is the management of the unresponsive patient. First, ensure the collapsed patient is in a safe environment. Then talk to the patient and try to stimulate and see if the patient responds. Shout out for help or call the resuscitation team. The approach to management of acute illness and trauma is the same for pregnant and non-pregnant patients with a few modifications. We follow the ABCDE approach. A. Airway. See if the airway is patent. Since the patient is unconscious, airway is at risk of getting obstructed by the tongue and the glottis. Turn the patient into left lateral tilt. The pregnant woman is tilted about 15 to 30 degrees to the left to move the pregnant uterus off the abdominal vessels, aorta and the inferior vena cava, thus improving the cardiac output. There are various methods of achieving this. Many hospitals have special wedge-shaped cushions, but the pillows and blankets can also be used. Then suck out any secretions which might be obstructing the airways and do the triple maneuver, which is the head tilt, chin lift and jaw thrust. But it's best to avoid the head tilt if you suspect any cervical spine injury. If not successful in opening the airway, an oropharyngeal airway or endotracheal tube must be used. Then, breathing has to be taken care of. First, look for chest movements, listen for the breath sounds, and feel for the movement of air for a maximum of 10 seconds. If breathing is present, give high flow oxygen. If breathing is absent, start CPR or cardiopulmonary resuscitation. This is done by giving 30 compressions at a rate of 100 compressions per minute with a compression depth of 5 to 6 centimeters at the center of the chest, followed by 2 ventilations until the defibrillators are attached. C. Circulation. Assess the pulse rate and blood pressure, and it is important to insert 2 wide-bore cannulae before circulatory collapse, where the blood vessels would be very difficult to cannulate, and manage hypovolemia or hemorrhage concurrently. Absence of breathing in the presence of a clear airway is now used as a marker of absent circulation, in which case CPR has to be commenced. After that, we have to assess the disability or the neurological status using the AVPU score, which is Alert, Response to Voice, Response to Pain and Unresponsive. Following the initial resuscitation, perform a Glasgow Coma Score. GCS of 8 or less indicates a compromised airway and will require intubation. And finally, exposure depending on the environment. Perform a full body examination of the patient. Monitoring may include blood pressure, pulse oximetry, ECG, end-tidal CO2 and respiratory rate. Consider urinary catheter and nasogastric tube depending on the circumstances. As the resuscitation of the patient is carried out, consider the differential diagnosis and correct the reversible causes. Assess the fetal well-being and viability by a cardiotocogram or CTG. Assess and review the trends of vital signs. Order investigations and plan specific management depending on the underlying cause. It is important to remember the resuscitation of a pregnant woman could be difficult due to several reasons. They have reduced lung capacity, reduced venous return in supine position, greater oxygen demand, increased risk of aspiration of gastric contents, and difficulty in intubation due to weight gain, edema, and increased in breast size. Please leave a like and subscribe if you like this video. And let me know in the comments below which topic you want to discuss over your next cup of coffee.